Hello, my name is Cheryl Wagner, and I'm going to be presenting on malaria prevention in rural India, teaching on a global scale. The problem. Malaria is a life-threatening disease caused by parasites that are transmitted to people through the bite of infected mosquitoes. Stagnant puddles, which are breeding grounds for mosquitoes, are common in India following the rains every year. India accounts for 75% of all malaria cases in Southeast Asia, and about 95% of the Indian population resides in malaria endemic areas. 80% of malaria reported in the country is in tribal, hilly, hard-to-reach, inaccessible areas, which are low-income rural areas of eastern and northeastern states. Malaria prevention is significant to the community health of rural villagers because, as noted, 80% of malaria cases in India are rural areas. Education regarding malaria prevention supports the United Nations Foundation's goal of combating malaria and other diseases. Learning needs assessments. Villagers in rural India are the prime population that need to be taught about malaria prevention and health practices. They must first be assessed for previous knowledge about malaria, readiness to learn and comprehension levels, resources available to implement prevention, willingness of the community to implement teaching. The priority outcome would be for the villagers to implement strategies that have been taught to decrease the incidence of malaria. The desired outcome would be to be reduced incidence of malaria among the villagers. This can be measured by calculating the percentage of villagers that currently have malaria before and after prevention strategies are implemented. Once these factors have been assessed, teaching can then take place. The health promotion model utilized to teach the villagers is the health belief model. The health belief model states that evidence has shown that individuals will take action if two conditions are present. One, there is a perceived threat, illness susceptibility and severity to personal health. Two, the individual is convinced that the benefits of taking action to protect health outweigh the barriers that will be encountered. This model is most applicable to the rural Indian villagers as the danger of malaria is evident and the prevalence of malaria-related deaths are an immediate and perceived threat. A plan must be developed to convince the villagers that certain actions that can reduce malaria are worth adopting and will reduce the risk of contracting the disease. Barriers to health implementation would be lack of belief that these practices will reduce malaria and lack of supplies, such as mosquito netting. Supplying netting to the community should be part of the plan to decrease malaria, and villagers should be encouraged to reflect on the incidence of malaria before and after preventative measures have been implemented. This may convince other villagers to implement techniques for effective prevention. The health promotion and education plan includes educating the villagers on realistic measures that can incorporate into everyday life that can reduce the chances of contracting the disease. The goal would be to reduce incidence of malaria-related mortalities by 50% in the next 3 months. The behavioral outcomes to indicate successful teaching would be recognizing the signs and symptoms of malaria early, such as flu-like illness, high temperature, jaundice, headache, diarrhea, and malaria, and seek medical attention immediately. The consistent use of insecticide-treated bed nets, keeping immediate surroundings clear of dirty, stagnant water, wearing loose-fitting garments, socks, long trousers, and long sleeves, especially at night, to prevent being bit. This plan would also include bringing supplies of insecticide, impregnated mosquito nets, and clothing for the villagers. This will enable them to have supplies needed to implement malaria prevention. Research and evidence shows that teaching health prevention strategies has helped reduce the incidence of malaria in India, and there is still a need for teaching in rural areas. A study in the Global Journal of Health Science showed that 51% of school-going adolescents in India had knowledge of symptoms of malaria such as fever. 57% knew mosquitoes breed in dirty, stagnant water, but none of these adolescents were aware about the new strategy of insecticide-treated bed nets. Only 20.7% of the adolescents were even using mosquito nets at all. A study by Antwi et al. Explored malaria prevention strategies in pregnant women in India. It showed that a majority of pregnant women did not regularly sleep under nets, and in except the Bastar district, there was almost a universal lack of insecticide-treated treatment of the nets in both these other areas. Sri Lanka, another study showed that Sri Lanka has drastically reduced the number of reported malaria cases when health education was provided and insecticide-treated bed nets were introduced, leading to a huge reduction in cases from the 2000s onwards. To determine whether or not teaching outcomes were successful, an evaluation must be made. Teaching will prove successful in at least 75% of villagers and are able to list the signs and symptoms of malaria and know how to get in touch with local health outreach programs that can provide medical help. Another goal would be 90% of the villagers demonstrate proper and consistent use of insecticide-impregnated bed nets, and that stagnant water is not found indoors or in immediate areas surrounding the village. Villagers also should consistently be wearing loose-fitting long sleeves and trousers. In conclusion, educating villagers in rural India is only the beginning of malaria prevention. The implementation of simple health practices can reduce the morbidity and mortality rate of high-risk areas significantly. It's important to continue to reevaluate the health practices that are successful and the ones that did not work. With education and diligence, malaria can be eradicated. And these are my references. Thank you.